Welcome to the Sir A.M. Silva oration, presented in conjunction with the annual academic sessions of the College of Surgeons of Sri Lanka. Please rise as the ceremonial procession makes its way to the hall.
Dr. Bhavanta Gamage, MS, MRCS, England, is a board-certified surgeon at the Colombo South Teaching Hospital, Carbohydrate, and a senior lecturer in the University Department of Surgery at the Faculty of Medical Sciences, University of Sri Jagadhanapura. He has a fellowship in laparoscopic surgery at Colchester General Hospital and a diploma in laparoscopic surgery, University of Strasbourg, France, and is a fellow of the Association of Minimal Access Surgeons of India. Bhavanta passed out from the Faculty of Medical Sciences, University of Sri Jagadhanapura, Colombo, with honours in 1998 and entered the Master of Surgery training program in 2001. He obtained Master of Surgery Colombo in 2005 and soon left the UK for his postgraduate training in Colchester. He was trained under the expert laparoscopic colorectal surgeon Mr. Tan Arunapalam at Colchester General Hospital. The SNE Center in Colchester has done pioneering work in the advancement of evidence-based laparoscopic colorectal surgery, and Bhavanta was extremely fortunate to be trained there. He is gifted with excellent laparoscopic skills and is equally skilled at performing many other endotherapeutic procedures, including therapeutic ERCPs, at ease. A reputed surgeon, highly sought after by patients and his fellow colleagues, he is looked after by his equally skilled wife, Manori, but a board-certified pediatric physician, a senior lecturer who works in the same faculty, and is a proud father of 2 girls. Introduction of enhanced recovery concept to laparoscopic colorectal surgery brought a new dimension to minimal access colorectal surgery. Returning from UK, using the best of what he gained during his training, Bhavanta not only introduced laparoscopic colorectal surgery to our department and to Colombo South Teaching Hospital for the first time, but also introduced other modern practices of laparoscopic surgery and the enhanced recovery concept. In fact, he is the first surgeon in Sri Lanka to introduce and practice enhanced recovery concept in our country, which he modified to suit our system. He published what he did, and his oration, which he was elected to deliver, is a testimony to that fact. I've known and seen the rise of young Bhavanta as a student in my faculty, intern in our university's surgical unit, and at Colombo South Teaching Hospital, and then as an enthusiastic surgical registrar and a senior registrar to pioneering laparoscopic surgeons in Sri Lanka, Dr. Sarath Kolluri of National Hospital, and our present president, Dr. Mahanama Gunasekara. All his trainers recognize Bhavanta as an extremely hardworking, skilled trainee who was prepared to take any extra core work whenever he was called upon to do so. As a colleague in the Department of Surgery now, his excellent clinical and technical procedural skills, his safe approach to patients, his empathic, kind, pleasant personality, Bhavanta is trusted and valued by all of us in our department. His upbringing, his childhood experiences, his all-round performance right through, Deputy Head Prefect at a reputed Colombo School DS Senanayaka College, an all-round cricketer in the formidable DS First 11 cricket team, the badminton and athletic teams, the President of the Literacy Society, was an excellent lineup to ascend to be a surgical leader. I congratulate Bhavanta and invite him to deliver Sir A.M.D. Silva oration of the College of Surgeons of Sri Lanka.
I call upon the President, Dr. Mahanama Gunasekara, to present Dr. Bhavanta Gamage with the
medal for the oration.
My dear sir, thank you very much for your kind, heartfelt introduction. I'm very fortunate to be guided and taught by a great surgeon and medical educator like you. The things I learned guide me right throughout my career. Mr. President, members of the Council, ladies and gentlemen, when the Oration Selection Committee appointed by the Council of College of Surgeons of Sri Lanka selected me for this oration, and our President, Dr. Mahanama Gunasekara, invited me to do so, I turned back the pages of time and found that Sir Arthur M. De Silva, ACMG, CBE, FRCS, was the first Ceylonese to become a Fellow of Royal College of Surgeons of England, being admitted to the fellowship in his first attempt at the age of 25. Dexterity, rapidity, and neatness characterized his work. He was a reputed surgeon who did his job with minimal incisions, bleeding, handling of tissues. Therefore, most of his patients recovered faster. In that context, it is a great honor for me to deliver this oration on enhanced recovery after surgery in his memory in 2018. So, Mr. President, I thank you, the Council, and the members of the family of Sir M. De Silva for this great honor vested upon me. Mr. President, within next few minutes, I would discuss about enhanced recovery protocol in colorectal surgery and show you how we implemented this novel concept in Sri Lanka. Why do you call enhanced recovery after surgery a paradigm shift? Before going into details, for those who are not familiar about perioperative care of patients with colorectal problems, let me go through briefly the way we manage these patients currently in most part of the country and some part of the world. When the patients are diagnosed of colorectal cancer, if the disease is advanced, especially with the patients with rectal cancer, they are directed to our oncological colleagues for neoadjuvant chemoradiotherapy. When the patients have early disease, they directly come to us for surgery. Whenever they come to us as surgeons, we want to have their bowels to be clean because we are going to resect part of the bowel and anastomose most of the time. Therefore, oral mechanical bowel preparation was used almost all patients. Conventionally, laparotomy and resection with or without a stoma was the norm. When we were medical students and junior doctors, our consultants want these patients to be filled with fluid preoperatively because to counteract perioperative fluid and blood loss. We kept the patient nil by mouth until their bowel sounds appear or flatus pass or stoma functions. Also, we kept the drains and urinary catheters for 3 to 4 days, sometimes more than that. And if the patients have not developed any complications, they were discharged around 7 to 10 post-operative days. I would call it a tradition that we follow in managing these patients with colorectal cancer during the perioperative period. As we all know, most of us do not want to change these traditions or break these traditions. Therefore, we continue to manage these patients in this manner. This tradition was followed across the world. These are the results coming from Europe and USA. And as you can see, more than 1,000 patients were analyzed, nearly in 290 hospitals. And 97% of these patients were given oral mechanical bowel preparation. The NG tubes were kept nearly 3 days. And oral feeding for solids was started around 5th to 6th post-operative day. An average post-operative hospital stay was about 10 to 13 days. Once, Sir William Osler said, I quote, "People do not die of their disease, they die of the pathophysiological effects of the disease," unquote. Mr. President, as healthcare professionals, no one knows how much we contribute to these pathophysiological effects. But I assume it is a significant proportion. The concept of enhanced recovery aimed at minimizing these adverse pathophysiological effects. It is a shift of a paradigm. What is a paradigm? A paradigm is a collection of beliefs that are held by a group of people. It's not just one belief held by one person. These beliefs are shared, passed on, and believed by generations. With the development of newer evidence, defects accumulate against it, and the paradigm is challenged, hence replaced by a new one. The concept of ERAS has shifted the paradigm of managing post-operative patients in the developed world. The main pillars of this concept are extensive preoperative education, operating by using laceless anesthetic and surgical techniques in order to minimize surgical stress response, post-operative pain and discomfort. Aggressive post-operative rehabilitation and early enteral nutrition and ambulation are other main pillars of this concept. We all know, with all due respect to the other specialties, surgeons are good leaders, and they are the best to develop and implement new changes. Danish surgeon Henry Kiel is one of the best examples. In fact, I would call him the best because he managed to convince the anesthetists on this concept. Mr. President, you would agree with me. If a surgeon can convince anesthetists to follow them, that itself is a great achievement. His concept was published in British Journal of Anesthesiology in 1997. He managed 60 consecutive patients on open colectomies according to his new protocol. His original paper was published in Annals of Surgery in year 2000. If you read this paper, the median post-operative hospital stay was 2 days. What did he do differently? He used multimodal approach to control perioperative physiology, therefore reducing post-operative morbidity and thereby accelerated the recovery. The work led to the concept of fast-track surgery. Later on, with the introduction of minimal access surgery and accumulating new evidence, several alterations to the original protocols have been added. A group of academic surgeons who worked tirelessly on this concept coined the acronym ERAS, Enhanced Recovery After Surgery. They started ERAS study group in 2011 in London. Extensive preoperative counseling, avoiding oral mechanical bowel preparation, preoperative carbohydrate loading, avoiding nasogastric tubes during the perioperative period, avoiding fluid and sodium overload, warming the patient during surgery, early mobilization, taking measures to prevent nausea and vomiting, early removal of catheters and drain, and establishment of early post-operative enteral feeding were the main aspects of this concept, in contrast to the traditional care pathway. In par with the world trend, we started applying this concept to our country with several modifications to suit the local infrastructure. Mr. President, the aim of this oration is to share our experience in the implementation of ERAS protocol, modified ERAS protocol in Sri Lanka. Also to show the results of an audit conducted among surgeons and surgical trainees to get an idea about the current perioperative care of patients with colorectal cancer in Sri Lanka. And based on our study results, to propose a national guideline to practice ERAS protocol for the patients with colorectal cancer in Sri Lanka. How did we start this in Sri Lanka? Before going into details, Mr. President, at this stage of my presentation, for the benefit of overseas audience, I would take 2 minutes to highlight the value of postgraduate surgical training in Sri Lanka. Because of our structured postgraduate surgical training in Sri Lanka, all our surgeons get minimum of 1 year, and most of us worked 2 years in overseas resourceful center during the latter part of our training. This opportunity I got was the origin of this project. After completing local training, I was fortunate to get 2-year laparoscopic colorectal fellowship in Colchester. where I had the opportunity of working with these two people, working in a center, pioneering center of laparoscopic colorectal surgery, the Assini Center, where I had the time, where I worked full time with these two eminent people. One, Mr. Tan Arulampalam, who is no stranger to Sri Lankan surgeons, and Ms. Jane Hendricks, who is the in-charge nurse of implementation of ERAS protocol in Colchester. Other than getting trained in advanced laparoscopic surgery for 2 years, I had the fortune in getting actively involved in implementation of ERAS protocol in Colchester with Jane Hendricks. Mr. President, with that experience, I came back to Sri Lanka with the firm objective of establishing laparoscopic colorectal surgery and enhanced recovery protocol in Colombo South Teaching Hospital, Sri Lanka. Implementing a new change to a decades-old system is a challenging task. This was also highlighted in an audit conducted by ERAS study group in London at the initial period of implementation of ERAS protocols. It showed widespread non-adherence to many steps in the protocol. In Sri Lanka, you can understand how difficult to implement change to an existing system. It is not only in Sri Lanka. I suppose even in the developed world, it is the same. It is paramount important that when we implement a favorable change, it has to be a sustainable one. Therefore, to have a sustainable ERAS protocol in colorectal surgery in our center, we started developing the center in 4 strategic aspects simultaneously. First, we took steps to improve the diagnosis and staging of patients with rectal cancers. Establishment of multidisciplinary team meeting in decision making in managing these patients was the next. Establishment of laparoscopic colorectal center was followed by introduction of enhanced recovery protocol in modified manner in our center. What have we done to improve the staging in rectal cancer? One of the main drawbacks to improve the diagnosis and staging of the patients with rectal cancer in state sector is lack of MRI facility in most of the hospitals. Colombo South Teaching Hospital is no exception. As we know, MRI pelvis is the gold standard in local staging of rectal cancer in the developed world. But due to the lack of facility freely in Sri Lanka, our patients do not get this benefit as required. Even if it is done, most of the time, the information the surgeon and the oncologist get may not be adequate to decide on the management. That is because of lack of reporting protocol. Therefore, I followed a course in pelvic MRI for colorectal MDT conducted by Professor Gina Brown, who will join us with us tomorrow in the College of Surgeons Green lecture. Also, I managed to get one of our consultant radiologists trained in the same hospital to perform and report pelvic MRI. We made the MOU between my university and one of the private hospitals to make this process sustainable one. This is our MRI reporting protocol. There, we pay more attention to what is known as circumferential resection margin and also extramural vascular invasions and lateral pelvic wall involvement. What is meant by circumferential resection margin? If you look at this picture on your left-hand side, you can see an early rectal cancer. You can see the rectum surrounded by mesorectal fat, which is enveloped by this black lining called mesorectal fascia. This is early rectal cancer, where the cancer has not gone beyond the rectal wall, not into the mesorectum. Therefore, this is an early rectal cancer. The patient can be operated directly when this is diagnosed. In contrast, the picture on your right-hand side is advanced rectal cancer. You can see the rectum, the cancer invading the mesorectum, as well as encroaching the mesorectal fascia. This is advanced disease. Mr. President, if a surgeon operates on this patient without knowing this fact, he is going to have a positive margin, and the local recurrence rate goes up to 40%. Therefore, no point of us talking about enhanced recovery in such patients. Therefore, ladies and gentlemen, the value of MRI in staging rectal cancer is invaluable. What is meant by extramural vascular invasion? If you concentrate this vessel outside the mesorectum, these are veins which are lying outside the mesorectum, you can see the image intensity is uniform. If you follow these veins up and down, you have the same intensity. In contrast, the vein inside this mesorectum, you can see there is heterogeneity in image intensity. That is because of tumor emboli. What is the significance of this? If we detect this early, our oncological colleagues will decide, even though the mesorectal fascia is not involved, our oncological colleagues may decide to give neoadjuvant chemotherapy for this patient. That is to prevent metastatic disease. Lateral pelvic wall involvement is the other feature that we look at in the MRI. If you see these two lateral pelvic walls, on your right hand side the pelvic wall is intact and it's normal. But if you compare with the other side, you can see there is abnormal area in this lateral pelvic wall. Therefore, this is advanced disease. MRI scan was thought to be a sophisticated investigation that was not an option for some of the underprivileged patients who are coming to state sector hospitals in Sri Lanka with rectal cancers. Mr. President, even though we do not have an MRI facility at Colombo South Teaching Hospital, I am happy to say that we perform pelvic MRI according to the said protocol nearly 90% of our patients. I take this opportunity to thank administration of the University of Sri Jayawardhanapura, Colombo South Teaching Hospital and private sector hospitals who supported us in achieving this task through an MOU between the stakeholders. Establishment of multidisciplinary team meeting in decision making on patients with colorectal cancer was a real challenge. Getting all the members together with their busy time schedule needs a lot of coordination. Our multidisciplinary team consists of surgeons, pathologists, radiologists, oncologists, stomach care nurse, in addition to the patient and the family. We have members from Colombo South Teaching Hospital, Apeksha Hospital Maharagama, Faculty of Medical Sciences, University of Sri Jayawardhanapura, and private sector hospitals in our MDT, which is held every fortnight. This benefits not only patients, but postgraduate trainees and consultants. We all know how much we learn after each MDT session. Establishment of laparoscopic colorectal surgery was the easiest task out of all, because I had the technical experience and knowledge about the technology. More than that, in Colombo South Teaching Hospital, first laparoscopic cholecystectomy was done way back in 1998 by using these older generation laparoscopes by Professor Mohan De Silva when I was a final year medical student. Therefore, basic infrastructure was already there at Colombo South Teaching Hospital. I have to build up on that. Mr. President, ladies and gentlemen, this is our laparoscopic theater. We have modern energy devices and good recording system and high definition laparoscope with high definition 30-degree and 0-degree telescopes in our theaters. We have patient warmers, and also we have modern theater table with anti-DVT pumps can be connected to the patient. These modern theater tables are very important in laparoscopic surgery. We can shift the table in head down tilt during laparoscopic procedure. We put the patient head down to about 45 degrees when we want to access deep cavity in the pelvis. This is how we position these patients before surgery. We connect the DVT pumps to the patient, connect the monitors to the patient, and put the patient's head down tilt to about 30 to 40 degrees, of course with the mercy of our anesthetists. We also have all the accessories that are necessary to perform laparoscopic surgery procedure. However, Mr. President, technology is not enough to achieve the goal. We have excellent and competent nursing and theatre staff to support us during the procedures. They do not have any time constraints during the surgical procedures. In addition, we have very good nursing staff and endoscopy staff supporting us during, they looked after our patients during perioperative period. In addition, we have energetic, young set of doctors who look after our patients perioperatively and also maintain our database. Ladies and gentlemen, I am proud to say we established fully-fledged laparoscopic center in Colombo South Teaching Hospital, and we are now having necessary infrastructure and human resources to perform almost all advanced laparoscopic procedures with regard to the colorectal cancers in our unit. As an example, in 2015, for the first time in the country, we entered into the International Transanal TME Registry by performing transanal TME, which is one of the latest developments in colorectal surgery, in a standard manner. And the first patient is doing really well after 3 years. We published this in Ceylon Medical Journal. When we compare the technique of colorectal surgery over the last years, I am happy to say that our task of establishing laparoscopic colorectal surgery is achieved, as more than 85% of our laparoscopic colorectal resections done laparoscopically, more than 85% of resections. This is our ERAS protocol, which we established in 2011 after a pilot project. We expedite the process by triggering a cascade of investigations once the tumor is detected at the endoscopy unit. We take dates for MRI pelvis, CT scan abdomens, and do basic investigations itself at the endoscopy unit. And also, when the patient comes to the clinic, they have all these investigations with their hand, and we direct them to the MDT discussions. At the MDT discussion, if the patient has got advanced rectal cancer, we will refer them to our oncological colleagues to give long course neoadjuvant chemoradiotherapy. If they have early disease, they will come to us and we offer them surgery within about 2 weeks. In advanced rectal cancers, once they get long course neoadjuvant chemoradiotherapy, they come back to us. What we do with them, as common practice in Sri Lanka, most of the unit, they are operated at the end of 6 weeks of completing neoadjuvant treatment. However, we do not do that. We wait for about 10 to 12 weeks. That is because the evidence is such, the optimal time for surgery after completing neoadjuvant chemoradiotherapy is about 10 to 12 weeks. Due to the infrastructure and patient social circumstances, we get the patient into the ward admitted 1 day prior to surgery. We pay particular attention to carbohydrate loading prior to surgery. This I will deal in few minutes. Our anesthetic colleagues are well aware about the protocol and make sure the patients are not given sedatives during pre-medication. Prophylactic dose of low molecular weight heparin is started on the previous day evening. We give the patient clear fluids until 3 hours prior to surgery with carbohydrate loading. For right colonic resections, we do not use any bowel preparation. But for left colonic resections, rectal resections, and total proctocolectomies, we use phosphate enema half an hour to 45 minutes prior to surgery. Our anesthetic colleagues will look after our protocol during the induction as well as maintenance during the surgery. At Colombo South Teaching Hospital, we are fortunate to have an excellent anesthetic department who will support us all the time, and we have got the best ICU in the country according to the assessment by the Critical Care Society of Sri Lanka. We follow the restricted fluid management during the perioperative period. As our patients are not getting oral mechanical bowel preparations, they do not have diarrhea. We keep them on clear fluids until 3 hours prior to surgery. They are not dehydrated because of this at the induction of anesthesia. When we perform the surgery laparoscopically, the blood loss is minimal as well as the insensible loss. Therefore, restricted fluid management avoids most of post-operative complications. Most of our patients get epidural analgesia, and we continue that in the first 24 to 48 hours. We mobilize these patients during the first 24 hours. We emphasize on starting oral fluids when the patient fully recovers from anesthesia, and start solids on the same day night if possible, or on the following day if not prevented by post-operative nausea and vomiting. First post-operative day, patients will have a walk in the ward with some support, and we continue to use low molecular weight heparin until they are fully mobilized. We remove urinary catheters on day 2 and drains usually on day 3. But the patients who have got long course neoadjuvant chemoradiotherapy, we have no hurry in taking out the drain, and the decision is taken by the operating surgeon. By day 4, we discuss the discharge plan, and day 5 most of our patients are discharged from the hospital. What are the changes we made to the standard ERAS protocol when we tailored it down to suit our Sri Lankan settings? I told you before, we had to admit the patients on the previous day because of various socio-economic reasons. In contrast, standard ERAS protocol advises to admit the patient on the same day to the hospital. We frequently use epidural analgesia due to the lack of patient-controlled analgesic devices to be used frequently. Intraoperatively, we employ CVP-guided fluid management because we do not have much facility to use transesophageal Doppler-guided fluid management facility. NG tubes were used in all our patients for the first 24 hours. In contrast to the standard protocol, NG tubes are not recommended. Selective use of drains to all low anterior resections, proctocolectomies, and abdominoperineal resections was our protocol. Post-operatively, ICU care was given overnight to most of our patients because we did not have a fully fledged HDU in our center. But recently, we got the fully fledged high dependency unit to our center. Therefore, most of our patients go back from directly operating room to this HDU. As outreach services are not well developed in Sri Lanka when compared to UK or Europe, we keep these patients in the ward until they are fully mobilized and the feeding is established, and discharged around 5th to 6th post-operative day. When the patient comes to the clinic prior to surgery or when they are admitted to the ward, we distribute these booklets to the patients. They explain their diagnosis, what is their perioperative management, and more importantly, what we expect from them to get their recovery enhanced. Mr. President, we designed a prospective cohort study on this. Ethical approval was taken from the Ethical Review Committee of the Faculty of Medical Sciences of the University of Sri Jayawardenepura, which is a FERCAP accredited ethical review committee. Consented 112 patients who underwent elective colorectal resections under my care according to the modified ERAS protocol from year 2011 to 2017 were included in this study. Mr. President, I would like to highlight some evidence for the salient steps that we are following in this protocol. What is the importance of carbohydrate loading? It had clearly shown to reduce preoperative thirst, hunger, anxiety, and postoperative insulin resistance. It also reduces postoperative nitrogen and protein loss. It will help in better maintaining lean body mass and muscle strength. data from randomized controlled trials have shown carbohydrate loading accelerates recovery and reduces postoperative hospital stay. This is what we used in UK. It contains 300 kilocalories in 200 ml bottle. We did not have such preparations at the beginning. What we used is 100 gram of glucose dissolved in king coconut water and asked the patient to drink 24 hours prior to surgery, and gave 50 gram of glucose 3 hours prior to surgery. Recently, we got what is known as preload. This contains, one sachet of this contains 190 kilocalories. We give two of these 24 hours prior to surgery and one of these 3 hours prior to surgery dissolved in water. Why we do not use oral mechanical bowel preparation? Oral mechanical bowel preparation is well known to cause adverse physiological effects attributed to dehydration and prolonged ileus after colonic resections. Also, risk of spillage of bowel contents increase the risk of postoperative surgical site infections. In addition, all surgeons in this audience will know, those who do laparoscopic colorectal surgery, how difficult to handle small bowel when it is filled with fluid after oral mechanical bowel preparation. Therefore, we do not use oral mechanical bowel preparations in our patients. I know there are new developments in this aspect, which I will discuss in few minutes. No sedations in pre-medication, as it affects immediate postoperative recovery by impairing mobility and oral intake. We use dexamethasone because it has been well proven that it prevents postoperative nausea and vomiting. We use this in pre-medication as well as at the induction. We make sure that the patient is adequately warmed during surgical procedure because hypothermia is well known to cause high rate of wound infections, morbid cardiac events, and increase the risk of bleeding. Contradictory to what we learned in the past, it has been proven beyond doubt that perioperative fluid restriction prevents bowel edema and interstitial lung water. Multicenter clinical trial in 8 hospitals using 172 patients have been published in 2003 Annals of Surgery. There, it has been clearly shown that fluid-restricted group has shown marked reduction in overall complication rates, wound healing complication rates, cardiopulmonary complication rate, in contrast to the standard group. Mr. President, now let me show you our results. We analyzed 112 patients, more than 70 of our resection. When we analyzed the mode of resection, more than 70% of our resections were laparoscopic. Nearly 20% resections were open, and we had to convert about 9% of patients due to various reasons. Out of the resections, 60% were anterior resections, about 15 to 16% were sigmoid colectomies, and about 4% were total proctocolectomies. When we analyzed rectal cancer patients, about 32% of our patients had advanced disease. They came to surgery after long-course neoadjuvant chemoradiotherapy. This 2-minute video clip will show you the difficult pelvic dissection in a patient, male patient who has had low rectal cancer, came to surgery after long-course neoadjuvant treatment. He has kindly consented to show next 3 video clips in this presentation. He was perioperatively managed according to our ERAS protocol. As I shown you before in the previous slides, we position these patients in extreme head-down tilt and use the gravity as a force of retraction during surgical procedure. We start the dissection at the sacral promontory. We used intra-abdominal carbon dioxide pressure about 12 millimeters mercury, and we use ultrasonic dissectors and high definition telescopes in our dissections. We use 5 millimeter 30-degree telescopes. Experienced surgeons who have done open low anterior resections in this audience will agree with me how difficult to access lower rectum in a male patient. The situation is worse when they have long course neoadjuvant chemoradiotherapy. But in laparoscopic dissection, if you are a well-experienced surgeon, we are in a better wicket. because the tip of the telescope acts as surgeon's eye and it is very closer to the field of dissection. You get high definition magnified view when we used high definition telescopes. This patient, as you can see, had neoadjuvant chemoradiotherapy, therefore a lot of free fluid accumulate in the pelvis during the dissection. This is because of the reaction to the radiotherapy. In such patient, we are not in a hurry to take out the drains post-operatively. Once we do the dissection posteriorly, we go anteriorly beyond the prostate towards the rectal junction. And when we have made sure that we have gone beyond the tumor, we use endo-GIA staplers to divide the rectum beyond the tumor. In this instance, I have decided to divide the rectum and make sure that the tumor is resectable prior to the getting control of inferior mesenteric artery. Inferior mesenteric artery, we get the control by applying hemolock clips and then followed by division. We extract the specimen through a small incision which is going through the umbilicus, because when the wound heals, the scar is very minimal. My assisting senior registrar will come through the rectum with the circular stapler, and we make the colorectal anastomosis between the sigmoid colon and the lower rectum. At the end of the anastomosis, we make sure we perform air leak test. And this is the specimen with intact mesorectum, and you can see apical hemolock clip. This is the patient 24 hours after surgery. The CVP line is removed and the patient is disconnected from intravenous fluid. We want the patient to get out of the bed as quickly as possible. This needs a lot of motivation. That is why preoperative counseling and motivation is important, not only to the patient but also to the family members. We want the patient to get dressed and walk in the ward with some support. Patient carries the drain as well as the urinary catheter, and we want the patient to do this a couple of times during the first 24 hours. This is the same patient on the second post-op day. They are being given free fluids, and also the catheters are removed. Catheter is removed and the drain also has got removed, and we want the patient to walk in the ward alone several times. All our patients were mobilized in the first post-op day, and majority of them were free of catheter and drains by day 2. When we analyzed our complications, nearly 18% of our patients had surgical site infections. About 3.5% of our patients had anastomotic leaks. When we compare this with other studies, our anastomotic leak rate, median hospital stay, and reoperation rates are comparable. This hospital stay in our study includes 1 additional day prior to surgery, but most of these other studies, they have admitted the patient to the hospital on the same day. Mr. President, after analyzing our results, we also conducted a survey to see the current practice in perioperative care in other units in the country. Majority of the the units do open surgeries, but more importantly, 40% of our units do laparoscopic surgery. At least they begin surgery laparoscopically. That is an important finding. When we analyze perioperative management, more than 70% of the time they use oral mechanical bowel preparations. Opioid analgesics are used nearly 90% of the time. Preoperative carbohydrate loading is used in about 20% of the time. Patients are kept nil by mouth for about 3 days. Clear fluids are started around 3rd post-operative day, and solids are started around 5th post-operative day. And most of the patients were discharged around 7th post-operative day. Mr. President, we made the following conclusions after the analysis. With the resources we have, we can implement ERAS protocol with some modifications to suit the local settings and produce complete comparable outcome with published data. It is safe alternative to the traditional practice of colorectal surgery in Sri Lanka. Some of the centers in Sri Lanka already practice some aspects of enhanced recovery protocol, but without uniformity. Therefore, we need a guideline to practice enhanced recovery protocol in colorectal surgery uniformly across the country. Today, there are health administrators in this audience. Therefore, Mr. President, as Henry Keeler did in early 1990s, surgeons in this country, while the anesthetics are listening in the audience, would like to propose a national guidelines to practice enhanced recovery after colorectal surgery. This is our proposed guideline. For the diagnosis and staging of rectal cancer, all patients should have colonoscopy or CT cologram. If this is not done preoperatively, at least within 8 weeks after surgery, we propose to get colonoscopy done. Value of MRI in staging rectal cancer, I have emphasized. Therefore, we would recommend to get all patients with rectal cancers MRI done prior to surgery. Contrast enhanced CT scan abdomens and CEA levels are commonly done in the country. Therefore, it is an accessible option. Value of colorectal MDT is very important. We should inculcate this habit of having MDT in all our surgical trainings. In fact, yesterday in our colorectal masterclass, we discussed about operating theater MDTs. So the concept of MDT in managing these patients is vital. These are the preoperative measures that we propose. Pre-admission counseling is very important in order to recover the patient faster. We all know optimized nutrition is must, but preoperative carbohydrate loading is our recommendation. Fasting protocol is 3 hours for liquids and 6 hours for solids. And we do not recommend any oral mechanical bowel preparation to our patients. However, for left colons, hip resections, rectal resections, and total proctocolectomies, we use phosphate enemas. DVT prophylaxis should be used in all colorectal surgery prior to the surgeries. No sedatives should be used in pre-medication. Prevention of nausea and vomiting is vital to start early enteral nutrition. Perioperative measures include the measures to minimize surgical site infections. That is, chlorhexidine shower prior to surgery, as we do it in our unit, prophylactic antibiotics before incision, and standardization of preparation of surgical field with povidone iodine is recommended. A multimodal opioid sparing pain management protocol is recommended. At the same time, prevention of post-operative nausea and vomiting and goal-guided fluid therapy is our recommendation. What are the post-operative interventions we propose? Early and gradual mobilization of the patient has to be done. Early post-operative feeding is associated with prevention of ILS. Therefore, it is our recommendation. Minimal use of opioid analgesics will help to mobilize the patient quickly. Early removal of urinary catheters and drains is the recommendation. However, this decision has to be taken by an experienced clinician. Mr. President, I saw question marks when I was discussing about our bowel preparations in the audience. At the same time, in your face, I discussed our protocol of bowel preparation. Let me clarify these doubts. The traditionally used mechanical bowel preparation for many years became out of practice with the emergence of evidence from several randomized controlled trials and this Cochrane review published in 2011. This was the basis of our protocol of not using oral mechanical bowel preparation in our modified enhanced recovery protocol. What is the current thinking in USA? large retrospective cohort study came from USA in 2015, supporting the fact that mechanical bowel preparation combined with oral antibiotics significantly reduces complications. In fact, combined oral mechanical bowel preparation and oral antibiotics, neomycin, is recommended for all elective colectomies in the American College of Surgeons and Surgical Infection Society in their guidelines. What is the position in UK? Professor Lobo's team from Nottinghamshire, in their meta-analysis including 33 randomized controlled trials and 13 observational studies, have concluded that mechanical bowel preparation, when compared to no preparation, there was no significant difference in terms of anastomotic leaks, surgical site infections, and intra-abdominal collections, mortality, and therefore length of hospital stay. This was published in World Journal of Gastroenterology in January 2018. What to follow? We do not know. Mr. President, as you have taught me in 2003, when I was a junior registrar under your care at General Hospital Anuradhapura, I really enjoyed that time, sir. What is the most important in preventing anastomotic leak are preoperative optimization, meticulous technique, and tension-free anastomosis with good blood supply. Up to date, this is not challenged. However, when we come to this dilemma, in my opinion, giving oral antibiotics, neomycin and metronidazole, which is used in UK now, is more important in minimizing surgical site infection and anastomotic leaks than oral mechanical bowel preparation, because anastomotic leaks are thought to be infective origin now. There are many studies coming up supporting this evidence. We talk about anastomotic health rather than anastomotic leaks now. In our study groups, however, we have not used any oral mechanical bowel preparation, nor have we given oral neomycin or metronidazole. Our anastomotic leak rate is 3.5%, and surgical site infection rate is nearly 18%. Most of these patients have had neoadjuvant chemoradiotherapy, by the way. But to answer this question more scientifically, I have designed a clinical trial to propose to compare patients who get oral mechanical bowel preparation and oral antibiotics with the patients who are getting phosphate enema and oral antibiotics to decontaminate the bowel. When we look at the feasibility of this trial, we found that neomycin, which was widely used in our hospitals a few years ago, is no more available in the country. There is no distributor or importer of this medicine. Therefore, we have written to the National Medicinal and Drug Regulatory Authority, and probably we will be able to get this medicine from 2019, and we will start the trial. Mr. President, ladies and gentlemen, I strongly believe that I have not wasted my time in trying to implement this modified ERAS protocol in colorectal surgery in Sri Lanka. I have shown you with evidence that we could do it with much better outcome compared to the traditional care pathway. More importantly, we can get comparable results with the rest of the world. Therefore, ladies and gentlemen, we are ready to shift the paradigm. Thank you very much. Mr. President, members of the Council, ladies and gentlemen, Sir M. De Silva oration for the year 2018 is over. But the orator can't leave this podium forgetting the people who cleared this pathway to this oration. Let me thank all my patients who contributed to this study. All my teachers and trainers, thank you very much for bringing me to this level. I was trained by Dr. Mahanama Gunasekara and Dr. Sarath Kumar Kolluge, who is not in this audience today because of his family commitment, and got the final molding from Professor Mohan De Silva. Thank you very much, sir. Let me thank all the members of our theatre staff, anesthetic department, and the nursing staff in University Surgical Unit Colombo South Teaching Hospital. Directors of Colombo South Teaching Hospital, thank you very much, sir, for all the support extended to us during the initiation of this project. Vice Chancellor of the University, Professor Sampath Amaratunga, who is here today in the audience, thank you very much, sir, for your valuable contribution. And our Dean, Faculty of Medical Sciences, University of Sri Jayawardenapura, Professor Surangi Achawardana, who is my anatomy teacher, thank you very much, madam, for all your guidance. Let me thank all distinguished guests who are here today. Thank you very much. If you are not there, no point of my talking this to the no point of my talk. Let me thank all my trainees, senior house officers and house officers who took care of all my patients during the perioperative care and also maintaining our database. Special thanks goes to Dr. Kesara Ratnatunga, who's getting his training, latter part of his training in Oxford, and Dr. Chamil Lakmal, and also Dr. Malaka Javadana, who supported me doing these slides. This is my second home, led by Professor Mahandi Silva and Deepaka Veerasekara. My senior colleagues, Professor Aloka Patirana and Professor Srinath Chandrasekhara. Thank you very much, sir, for your kind guidance in my clinical work and research work. Tejana, Malik, thank you very much for all your moral support given to me in submitting this manuscript. We are a family and we all understand the value of sacrifice in the process of development. My dear parents who are in the audience today, thank you very much for all your hard work when you have done to bring me up to this stage. Mr. President, if not Manori, who gave me her time, compromising most of her commitments, I would not have done this work. Thank you very much, Manori. I have also thanked Lihini and Manuli, who enhanced recovery of both of us, not by giving carbohydrate loading, but by simply greeting us with their love. Thank you very much.
Dr. Gamage, first of all, can I congratulate you on such a wonderful exposition of the use of enhanced recovery after colorectal surgery. I'm sure that Sir Arthur de Silva would have been proud to have heard your oration today. I think what you have done is to bring home a quantum leap in clinical practice. And I think that only happens once or twice in any surgeon's lifetime. And I think there's no doubt that you have shown a pragmatic approach to tailoring the new concept and delivering it locally. And I think you are to be congratulated again for doing that. Very importantly too, in the early part of your presentation and now right at the end, you've shown the importance of being part of a team and leading a team and teamwork, because clinical delivery is so much more than a surgical operation. It's all of the other aspects that you've demonstrated us today. And then finally, you've taken the big step of auditing your results against international standards, which you have matched and indeed exceeded in places. So I think for any young surgeons in the audience, what you've seen in the last hour is a textbook example of how to introduce a new concept and deliver it safely into practice. I congratulate you. Thank you.
Dr. Bhavanta Gamage, our orator this evening, will be presented with a special gift by Dr. K.L. Fernando, who is one of the distinguished past presidents of the college.